I'm Dr. Paul Wang, Editor-in-Chief, Circulation, Arrhythmia, and Electrophysiology, with Dr. Miguel Valderrábano, Professor at Houston Methodist and Weill Cornell Medical College, to discuss his paper, Cardiac Afferent Denervation Abolishes Ganglionated Plexi and Sympathetic Responses to Apnea, Implications for Atrial Fibrillation. Welcome, Miguel.
Thank you, Paul.
I wonder if you would start discussing the purpose of your study.
So broadly speaking, we all know there is a connection between apnea, sleep apnea, and atrial fibrillation. The mechanisms that make that connection are poorly understood. It's not like we're going to try to explain everything, because the connection is very, very complex and multifactorial. But we wanted to explore one aspect of that connection, which is acute apnea and how it affects what the electrophysiological consequences acute apnea has. And, you know, we had some knowledge about the nerves that coat the left atrium. The innervation of the heart is a fascinating issue, fascinating topic. We know that the left atrium is particularly rich in innervation. We know that there are sensory neurons as part of that innervation. And we thought that, well, sensory neurons must be there for a reason. And from basic studies, we know that sensory neurons in the left atrium, ex vivo, when you put them in vitro, they respond to certain stimuli. They are mechanoreceptors. They respond to low pH, to hypercarbia and hypoxia. So I thought it was a great setting physiologically, meaning apnea could be a great setting to create all those. So hypercarbia, hypoxia, acidosis, and perhaps some mechanical stretch if the PA pressure goes up, that the sensory neurons would respond to. And in some general reading about sensory neurons, we found some work by Erwin Zucker from Nebraska, where he had found this compound, resiniferatoxin, that binds to sensory neurons receptor, this TRPV receptor, maximally activates these neurons, and then after a few minutes, the neurons die out of calcium toxicity. So I thought this is a great way to check, to maximally stimulate these neurons, check what they do, but in the setting of apnea. So it led to a complex set of protocols. And you know, you see the final result, but this work has been lingering for a few years now. But I can tell you more about the details of what we did.
No, thank you. Great. So maybe you could share, Miguel, the key findings of your paper with our audience.
So the key findings is, number one, there is a relatively well orchestrated and relatively consistent autonomic response to apnea. And to summarize it in a quick way, the first thing that happens is there is probably a sensory neuron activation that we can demonstrate by ganglionated plexi firing when we record that. As apnea progresses and oxygen saturation drops, there is first these vagal bursts of firing that we record in the vagus that coincide with oscillations in heart rate and blood pressure. And it's very interesting that the bursts match the upsloping phase of this oscillation. So when you get these bursts is when the heart rate is going up, which to me was counterintuitive, but actually had been reported by Peng Cheng and others in the past. And then simultaneous or near simultaneous with this vagal burst, we get a tonic increase in sympathetic activation, as we can see in the ganglionated, in the stellate ganglion. This sympathetic activation is associated with increases in blood pressure. Now, we get to a point where in the protocol, when we reached oxygen saturations of 80%, we restarted breathing. So that was the end of apnea. Many times apnea, the oxygen saturation kept going down, even though we had restored ventilation. But again, number one finding is that consistent autonomic response to apnea. with GP activation, vagal burst, and tonic increase in sympathetic activation. The second part of our paper is when we give this drug, dracaenin, first we go through an acute phase where it is really impressive. It seems like the animal gets into an autonomic response to pain. The animal is obviously intubated and sedated, but you get increased, a doubling in the blood pressure, sometimes tachycardia, sometimes ST segment changes. Those can be dramatic, and over a few minutes, sometimes 20, 30 minutes, things go back to the baseline. Consistent with what we know in vitro of the RTX effects of activation of sensory neurons followed by ablation of sensory neurons. Then after we had let the RTX do its effect and things are back to the baseline, if we repeat apnea, the apnea is different now. The response to apnea is different after RTX. And how so? We don't see the GP activation, at least as much. And we still see the vagal bursts, and we don't see the sympathetic activation. So that's as far as the autonomic response. But as far as its connection to atrial fibrillation, protocol 2 showed that in apnea at baseline, the effective refractory period of the atrium shortens. During apnea, you get short TRP, and in all dogs with a single extra, we induce AFib. Not every time, but in all dogs, at least once, we induce AFib with a single extra stimulus. After RTX, the refractory period, instead of shortening, actually prolongs during apnea, and a single extra never induced AFib. Of course, that's not to say that we made the dog immune to AFib, but at least a single extra stimulus during apnea was able to induce AFib all the time in baseline apnea and never after RTX. And we blunted that shortening of the effective refractory period. So we make a case to defend the idea that the sensory neurons are an integral part of the response to apnea and its connection to atrial fibrillation.
Great. Well, that's really fascinating and really important work, Miguel. If you could summarize, what do you feel are the key implications, both for clinicians and researchers, of your key findings?
So for the clinician, this is just an interesting finding. We still don't have a clinically relevant, we're not going to change the practice with this, obviously. But I think in terms of research, I think we can see sensory neurons as a potential target for therapeutic interventions. I'm not saying that we should use this drug because it's, obviously that we're a long way from doing that, like any new compound. But I do think that a mechanism to target sensory neurons makes sense to prevent apnea-induced atrial fibrillation. What's also interesting to me is we've seen a lot of work in the GP and the role in AFib from Sherlag and the Oklahoma group, Sunny Po, Jackman, and others. But most of the work so far targeting the cardiac innervation has been ablation. Its destruction has been about killing it. And what I wanted to also try to be a little bit more sophisticated, try a chemical that targets the sensory neurons as opposed to just plain burning. So conceptually, I think if we understand how these neurons work, we would be able to manipulate them pharmacologically, not killing them, to achieve a protection against AFib. I mean, that's our goal.
Great. Well, thank you. This has been Dr. Paul Wang, Editor-in-Chief of Circulation, Arrhythmia, and Electrophysiology, with Dr. Miguel Valderrábano at Houston Methodist and Weill Cornell Medical College, discussing his paper, Cardiac Afferent Denervation Abolishes Ganglion, Plexi, and Sympathetic Responses to Apnea, Implications for Atrial Fibrillation.
Thank you very much.